just adjust my screen back. And then...
Okay, perfect. I'll let Mike get set up there, but in the meantime, welcome everyone. Thanks so much for sticking around to the end of the day. It's been an awesome session. I have learned a ton. So thank you to all the presenters, and special thanks to Dr. Patterson and the Heart Institute for putting this on. Without further ado, I want to introduce our first speaker. So Dr. Garshick is a cardiologist and assistant professor of medicine and dermatology at NYU Langone Health. Dr. Garshick did his internship and residency at Columbia University Medical Center, then went on to do his fellowship as well as research fellowship and a master's program in clinical investigation at NYU Langone Health, where he now directs the cardio-rheumatology program. He's co-chair and co-founder of the Cardio Room Working Group within the ACC and directs a yearly cardio inflammation symposium, which I'll put a plug in for. That's happening in mid-April, so we should all check that out. It'll be a great session, and his mandate is really to advance the specialty of cardio-rheumatology, and it can speak from personal experience that he is an amazing speaker and a titan in the field of cardio-rheumatology. So it's a real honor to have him present today. Thanks, Michael, for joining us to talk more about immunosuppression in pericardial disease.
Thanks, Kevin. It's a pleasure to be here. Thank you for the invitation, and I trust everyone can see my screen. So
yes, we can. Yeah.
Great. Okay. These are my disclosures. Okay. So I wanted to do this talk in this presentation within the construct of a clinical case. Someone who I saw probably at this point 7 or 8 years ago. And it's interesting how his case evolves as how we think about treating pericarditis has evolved as well. So he's a 31-year-old male who presents to the emergency room with fever, chest pain, abdominal pain, and shortness of breath. And there's no diagnostic mystery for this case, so ultimately we think this was pericarditis, and we'll talk about why in a minute. But and this is more of a theoretical question, which of the following is true? The absence of a pericardial effusion excludes the diagnosis of pericarditis. You need those characteristic EKG changes to diagnose pericarditis. If you have a negative troponin, that excludes the diagnosis of pericarditis, or none of the above. So this patient's EKG that we saw earlier was one of sinus tachycardia. And this is the EKG we all think about when we diagnose pericarditis, meaning there's diffuse ST segment elevation that don't necessarily correspond to coronary anatomy, PR depression, and PR elevation in AVR. But in reality, the most common EKG finding you see during an acute pericardial flare is one of just sinus tachycardia, which is what our patient had. And I think this is a really important concept because this is an update from our 2025 ACC clinical guidance statement for pericardial disease, where we've taken out that concrete, do you have pericarditis? Yes. Do you have pericarditis? No. And I would say this is much more what I see, or many of us see in our clinical practice, which is there's sometimes some diagnostic uncertainty, and it's not absolutely no, but it's unlikely or possible or definitive. And so we generally require that pleuritic chest pain or an equivalent, which can just be shortness of breath, a friction rub. We have these EKG changes, but you don't need those EKG changes to diagnose pericarditis. Instead, you can have the inflammatory markers, which I find incredibly helpful, especially when broadening my immunosuppressive therapy, cardiac imaging, and that can come either from echo with a new effusion or from active findings on a cardiac MRI. So what happened to our patient? Well, we ruled out infection, and ultimately we got an echocardiogram, and I believe this should be playing here, showing a pretty large pericardial effusion. There were no signs of cardiac tamponade. His troponin was negative. His white blood cell count was elevated, and the CRP, his biomarker of inflammation, was incredibly high at 150 milligrams per liter. And so he was discharged on ibuprofen as well as colchicine. So that comes back to the next question. Which treatment of acute pericarditis has been shown to reduce the complications of multiple clinical trials? NSAIDs such as indomethacin, ibuprofen, we have aspirin, colchicine, or prednisone. And this comes up again and again. In NSAIDs, they help with pain, but it's a bit controversial if we think they change the disease physiology, if we think they are just helping with pain or the disease modifying. I think it kind of depends who you talk to. And that's a bit different than colchicine, which we think of as something that can be disease modifying in terms of treating some of the underlying central drivers of pericarditis. In this case, we think of that specifically the aggregation and the formation of the NLRP3 inflammasome, eventually with the use of colchicine leading to downregulation of IL-1 beta, IL-6, and CRP. And so NSAIDs are important for treatment belief, but there's really been very, very little to no clinical trial data on the use of NSAIDs in the treatment of acute pericarditis. And that's really much different than colchicine, which has been shown in multiple clinical trials to reduce the recurrence of pericardial disease or pericarditis. And it's also important how you give it, because I get a lot of consultations where, oh, the patient didn't tolerate colchicine. But there's somewhat of a weight dependence to this. And so you can either load or you don't have to load. But if they're of a lower weight, specifically less than 60 kilograms, once a day is okay. And we generally don't try to force the twice a day issue unless their weight is significantly elevated. And so the use and the evidence behind colchicine in the treatment of pericarditis has been shown in multiple clinical trials, such as the COAT trial with 120 patients, and it's been shown in 2 recurrent pericarditis trials, where instead of giving it for just the 3 months, we give it for the 6 months, or sometimes even longer to reduce the recurrence of pericarditis. We also have evidence for the prevention of pericarditis in those undergoing a pericardiectomy. So giving colchicine for a stimulus of pericarditis, which is cutting the pericardium open during a cardiac surgery, showing a reductions in recurrence as well. And so as a mainstay first-line therapy for pericarditis, I mean, if you look at the numbers needed to treat, it's actually pretty impressive, almost hard to believe, that you need between 3 to 4 to 5 treating 3 to 4 to 5 individuals to prevent 1 pericardial flare. That's pretty impressive. And so when I give colchicine, I talk about some of the patients. I talk about what is the maximum dose you can tolerate if you're not able to tolerate. And we go through the side effects as well. And my goal is really to get them on some sort of chronic colchicine therapy, especially if they've had multiple recurrences, because I'm generally trying not to increase my immunosuppressive therapy unless they've failed colchicine or they really can't tolerate it. So this patient appropriately was discharged on high-dose ibuprofen for his pericardial pain. He was also discharged on appropriate colchicine, but what happened to him? Well, 3 weeks later, he was admitted for chest pain and shortness of breath. His CRP was decreased to 10 from 150, but he had a large left pleural effusion. It was drained and he was discharged again. So what happens to him? Well, 2 weeks later, he comes back with recurrent chest pain again. He had a small pericardial effusion. His CRP jumped. This was not at our hospital. He had this recurrent left pleural effusion. And again, I think this case really highlights the change in how we think about pericardial disease over time. The team wasn't so sure of what was actually happening to this patient. He actually underwent a VATS with a biopsy of the pleura because they didn't necessarily think about pleural pericarditis at the time. Ultimately, that was the diagnosis, and he was discharged on 800 milligrams of ibuprofen and colchicine in pretty high doses. So he's seen as an outpatient 1 month later. His echo shows no pericardial effusion, but he's got some dull, nagging abdominal pain after each ibuprofen dose. He's got no chest pain, no shortness of breath. He's feeling pretty decent, and his CRP is 3. So you have a patient who's had 3 flares. CRP is finally low, and he's got some inklings of belly pain on industrial-style NSAIDs. So what do you do at this point? Well, his CRP is not less than 1. It is quite low. He's feeling good, but let's just continue the medication. Should we decrease the ibuprofen? Do we say, you know what, he's failed ibuprofen, he's failed colchicine, let's switch him to prednisone? Do we need to get a cardiac MRI? Do we switch to an IL-1? So this patient at this point, you're trying to get a sense that he's of a more higher risk phenotype. And in the back of your mind, as you are trying to explore what are the treatment options for him, you start thinking, well, this isn't my typical run-of-the-course idiopathic pericarditis. Do I have to start thinking about alternative reasons or other central drivers of why this is occurring? And this study is kind of old, it's from the 1990s, but I still enjoy it. And I took 100 patients. It's just what is the etiology of the pericardial disease? Well, even in the 1990s, I think that we still had some more disease, higher risk phenotypes of patients coming into our hospital, Still, the most common cause of pericarditis was idiopathic, meaning we just don't know. And frankly, for me, I lump viral-induced and idiopathic into the same category because we're not necessarily going to treat a virus unless they're very, very specific ones. In the back of my mind, I think, does this patient have a metastatic cancer? Well, usually by the time these patients get to me, they've had some sort of CT scan, and in general, it does not show a malignancy. I work at a city hospital, so we rarely see TB. I've seen a cryptococcal pericarditis once or twice. I deal with a lot of cardiorheumatology, so in the back of my mind, do they have a collagen vascular disease, lupus and RA being the most common? And that's generally where I start looking into my differential as well. I think about connective tissue disease, infiltrative disease, autoinflammatory conditions, vasculitis, etc. So for these patients, and for this patient in particular, these diagnoses are now starting to go through my mind. And by the time they've had several recurrences, I start to do more of an extended or broad workup. So this patient's had negative HIV, negative hepatitis, hep C, and negative quant gold. He come to me after numerous CT scans, so I didn't think we were missing an active cancer or an active infection. And he had a whole host of rheumatologic serologies and a rheumatoid factor, et cetera, that were all negative. But in this setting, unfortunately, he was actually admitted 2 weeks later with severe pleuritic chest pain and a fever again to 100.6. So at this point, he's been on industrial style NSAIDs. We had chosen to go down slightly from his 800 to a 600 because of that dull abdominal pain. But he flared. He came in 2 weeks later with a CRP of 240, but he had no effusion, and he had a little mild white count. So this patient, we've ruled out autoimmune disease. We ruled out infection. He's clearly shown to us that he's a recurrent phenotype, meaning this keeps happening again and again and again in these failing colchicine. Is this weird? Is this rare? Who is this patient? Well, this is a flow chart I particularly enjoy. And so in these patients with acute pericarditis, what I tell them is that 15 to 30% will have several recurrences over their lifetime. That's generally going to be okay. So hopefully he's not going to be stuck in this autoinflammatory loop that this patient that I'm talking about probably is. But in those 15 to 30% who have recurrent episodes, now there's 6 to 7, 8, 10%, and they have these episodes again and again and again. And I generally find the hardest to treat without some of our newer agents are these young individuals who you haven't identified a specific cause. In the back of my mind, I'm also thinking, has this patient developed a really severe complication that's more emergent than just these recurrent episodes again and again, specifically just tamponade and progressing to constriction? And that also, how many times they've had tamponade, and are they progressing to restriction or constriction? That also starts to dictate to me how aggressive I'm going to be with more aggressive anti-inflammatory therapy. So regardless of the cause, though, once you've gotten caught in this autoinflammatory loop, recurrent episodes of fever, CRP elevations, failing colchicine, we think that in general, there's a central role of the NLRP3 inflammasome in this autoinflammatory pericarditis. And that's where the mesothelial cells undergo some sort of damage, whether it's cardiac surgery or something else, or idiopathic or a virus, we just don't know. It leads to inflammasome, which is this multimeric protein complex at assembly. And that leads to IL-1 beta activation. It leads to IL-alpha activation too through a slightly different pathway, IL-1 alpha activation, and of kappa beta upregulation as well. And that leads to a whole host of inflammation and inflammatory response. And the inflammatory response is really characterized, I think, also by CRP elevations. That's how we capture it biochemically, and also fevers. So in this patient, what did he have, and what could we have predicted that he was going to be this higher risk autoinflammatory phenotype? What are the high risk features of our patients in general? Well, he had a fever. I find oftentimes lack of response to inflammatory biomarkers at 1 week can be indicative of this high risk phenotype. And now this is not our patient, but the subacute response, meaning they have this low grade pleuritic chest pain, shortness of breath. They have these mildly elevated CRPs, not this patient. These patients also tend to linger, and I find these are the ones who you're really starting to think about more aggressive therapies for. And it's not that uncommon that our pericardial patients, even if it's rare to go on to develop recurrent pericarditis, many of them will be a little bit more complex, and I would include troponin elevation and perimyocarditis in here as well. So what should we do with our patient? Well, This is again circa actually pre-2020, so like the 2017-18 era. Do we continue colchicine and increase the ibuprofen back to what he was at before? You know what, this is ridiculous. Do we start prednisone? Do we do a cardiac MRI guided approach? Or do we switch to IL-1 inhibition? So he was hospitalized at this point, and we got an MRI. And what did the MRI show? Why did we even get it? Well, this wasn't really a diagnostic mystery. We were pretty sure he had pericarditis. He had a gross elevation of CRP. He had a pericardial effusion, pleuritic chest pain, fevers, etc. But for us, this was important to understand, first of all, is he trying to develop some of those complications of pericarditis that we get concerned about, such as constriction, or in his case, maybe an effusive constriction physiology. How much late gadolinium enhancement is present? We look at a few things on this MRI. Specifically, we look at, and then you're going to have a whole lecture on this later, so I didn't want to go into it in too much depth. But there are a few things that we look for. First, I always look for, was the MRI of a decent quality? Was there good fat suppression? What did the patient move? Did we get good imaging? Because I find the pericardium generally can be very thin, not in this patient's case. And so I can get these false negative MRIs, sometimes even false positive MRIs, if it wasn't a good enough image quality. So in this case, we look for increased pericardial thickness, which he had, that's the bottom left. We look for T2 edema, meaning showing active inflammation. And then we look for late gadolinium enhancement of the pericardium. So is there contrast uptake into the pericardium? And normally that shouldn't be the case. The pericardium is avascular. But when you get this constant injury, you get to neovascularization, fibrosis, proliferation, expansion of the extracellular space, and that attracts the contrast to it. So we look for specifically good quality studies, pericardial thickening, T2, LGE, and any signs of constriction of is the heart starting to get affected by the pericarditis. And it has prognostic implications. And if you take those things, if you take the chest pain, the CRP, and the late gadolinium enhancement, it all increases the flare. And on top of that, the MRI can help us figure out what stage is this patient in. And I actually really enjoy this figure here. We're in the acute pericardial episode. You get that T2, that's the edema in the pericardium. You get the late enhancement, that's the LG, the DHE. And recurrent, it can be a little more variable. You may or may not see T2, you get the late gadolinium enhancement, chronic, and then burnt out, where you tend to get calcific. And even though I really like this image, it doesn't necessarily always hold true. There are plenty of times we see late gadolinium enhancement with no T2. I just had a constriction case the other day where there was no T2, no late gadolinium enhancement, no calcific pericarditis, and we still took him to the OR and we found all this. So I'd say the MRI really is just one part of the ongoing story. And we sometimes will track this for a treatment response. That's the other reason to get the MRI. How well is the patient responding to therapy? Are they having ongoing active symptoms 6 months in, and you don't see that progression from resolution of T2, resolution of late gadolinium enhancement? Is there an issue with your disease treatment? This actually happened to me, a patient about 6 months ago. He was on what I thought was good, appropriate IL-1 inhibition therapy. He was having some squirrely symptoms. We did a repeat MRI. He had gross T2 with late gadolinium enhancement. So the T2 indicated active inflammation. Said, what happened? How are you doing? This is very surprising. Turns out he wasn't taking the right amount of medication. He was taught how to do it wrong. So this caught with the MRI, and granted I could have asked him, but I was somewhat surprised because this never happened to me before, but this caught a potential issue with the medication and the reason why he was flaring. So there's been a paradigm shift in these patients with recurrent pericarditis, and this is coming from the 2025 clinical guidance statement, where after you still have this initial NSAID colchicine treatment, if you respond, great. But if you don't respond, it used to be in a lot of our guidelines, okay, your second line is always going to be prednisone. And this is not necessarily to tell you, well, it should be one or the other. But I think the real rule of thumb here is that if the patient is flaring on or they can't tolerate some of our gold standard treatments, meaning colchicine, we now have a lot of options, of which you can either go prednisone or you can go more targeted therapy against that inflammasome specifically, which is with an IL-1 treatment. So if you choose to use prednisone for your refractory recurrent pericarditis patients. And I generally find I don't go to this for my young patients who have a multiple episode. I go to this for patients who maybe have one incompleted episode that are older, they're already on the prednisone and then wean. It should, for the most part, still be second line, except for select cases such as autoimmunity. It's okay to start at a lower dose. It can have side effects. Maybe it's associated with recurrence. I think the only real true rule of thumb is it requires a very, very slow taper over time. I go extremely slow. What are the indications to use prednisone? Well, specific rheumatologic disease. I would say this is taken out. I never use it in combination therapy. If I find I'm switching to prednisone with NSAIDs and colchicine, you're really setting yourself up on complications, and I'm going to other treatments. Again, failures of aspirin or NSAIDs and colchicine. Specific conditions, I find I'm very comfortable with prednisone in pregnancy, so I'll reach for that before an IO1. And then I use it as a bridge a lot, meaning it can take a while to figure out what you want to do with these patients, how long it will take to get the IO1 approval, how do you get that, what the pharmacy, which pharmacy is going to give it to you. And sometimes these patients need to be treated quite quickly, so that's when I default to prednisone. Important considerations: infection, osteoporosis. I always put them on PPIs. I always put them on PCP prophylaxis when they're over 20 milligrams for greater than a month. Biggest issue for me, I find, is the osteoporosis and the cataracts. I find patients complain about, and the lack of sleep. That's probably the biggest problem, is patients who claim they can't sleep while they're on it. And that's probably what makes them the most miserable in the weight gain, in my mind. There are issues with it. For example, it's associated with recurrence over time. And again, it's because you're only giving prednisone to patients who have had multiple recurrences, or is it the prednisone itself? I think it may be up for debate, but in general, I think most of us feel that the need for prednisone or the giving of prednisone can increase the risk of recurrence. So this patient, what happened to him? Well, he was actually quite sick. This was this was actually in 2019 or so, pre-rilonacept IL-1 inhibitor therapy approval for pericarditis. So he started on prednisone, ibuprofen, colchicine, a high-dose PPI. And over the past 3 months, we just couldn't get him down. Every time we tried to go down the prednisone, he flared. So he was really caught in this autoinflammatory loop, a persistent inflammasome activation with CRP elevation. He was absolutely miserable. So again, we have this imaging guiding approach to pericarditis, and he's starting to fit into this rubric even back then, where we had this patient has multiple recurrences, he's failing weans, he's this inflammatory phenotype with high CRP, late gadolinium enhancement. And so he's really someone at this point who, no matter what decade you're in, you have to start thinking about alternative therapy such as IL-1 inhibition. And now, thankfully, we have pretty good evidence that in select patients it works. So we have the AirTrip trial, which for anakinra, which is that short-acting, once-a-day IL-1 inhibitor. We have Rhapsody, which is a trap inhibitor, and we also have another medication too, a Russian medication, showing efficacy. So when do we start drawing these for these IL-1s for this refractory pericarditis? And at this point, I think the biggest important thing is it can be second line, just like steroids. And that's really how to think of it, is that, when you have a patient who's flaring, you get to pick one or the other. Now, when you're giving these medications, there's a few rules of thumb. So anakinra, you don't need a loading dose. For rilonacept, you do. I never give canakinumab. There are case reports of it working, but again, we think of that pericarditis caught in this autoinflammatory loop as being caused by both IL-1 beta and IL-1 alpha. Canakinumab just inhibits IL-1 beta, so it's not necessarily going to work as well, even though it's attractive because it's given monthly. This is an old slide, and I'm going to go into this, but the duration is really one of the big unknowns. In these patients who have had it for a long time, this is 6 to 8 months is probably not enough. I always taper at this point, and we have rules on monitoring pregnancy, lactation, etc. There's really very little data on rilonacept in pregnancy. And so if I were to have a pregnant patient, even though some of us feel anakinra may be okay, I generally stick to colchicine and low-dose prednisone. What are the side effects? And this is probably one of the most important considerations, especially with our IL-1 inhibition therapy. Patients can get injection site reactions. Rilonacept, 30%, 40%, 50%. I would say my own experience is less than this, but it can be quite uncomfortable. I've only had one patient that was not able to tolerate the injection site reactions on rilonacept. And there are some tricks to it. For example, you can treat after the injection with cortisone, not the hydrocortisone you buy over the counter. It usually generally needs to be prescription straight. I also will give antihistamines just before and just after the injection. That seems to really help as well. And sometimes, many times, once they're on a stable dose, it's very easy to jump to every other week of rilonacept or to space out the anakinra dosing, and patients tend to do quite well. So based on these types of strategies, most of the time you can get them to tolerate the medication. And that's especially important when some patients refer to you with this gross allergy to IL-1 inhibitor therapy, but you really need to use it. It's important to take a really strong history of what the allergy actually was. We do see elevation in blood lipids, whether that's correcting inflammation or the effect of the drug, I'm not so sure. I rarely see neutropenia, and we're going to talk about infections in a little bit. So what are the considerations when giving this? Well, anakinra is really attractive when you're not quite sure what's going on. Lasts for 4, 6, 8 hours, kind of easy on, easy off. One of my colleagues did a study where patients started to get pain relief in as little as 6 hours with anakinra. In the US, at least, that's the only IL-1 inhibitor that we can give in the hospital. So it's extremely attractive, and I routinely give it in the hospital when I want to use IL-1 inhibitor therapy. And generally, we'll start it. I'll come the next morning, and the patient's eyes will be lit up that they're so happy that their disease, that they have some sort of pain relief. It is given every other day, and I find it personally to be a terrible medication with my dialysis patients. It's, even though you have to adjust it for renal failure, I find it erratic and hard to give, and I don't necessarily find that for rilonacept, which is not cleared through the kidneys, and much easier to give. So what is rilonacept, which is in the US an FDA-approved medication for the treatment of pericarditis? Well, it's a trap inhibitor. It gets both IL-1 alpha and beta. The biggest issue with this cost is drug is extremely expensive. It requires prior authorization. It's not carried in hospital pharmacies, so you really cannot get it acutely. Even though people say, well, you can get a starter pack, you can start it right away. I would say that's just not the case. You need at least budget maybe 2 to 3 weeks of your time, unless you're extremely aggressive, to get this medication into your patient's hands. And that's why I frequently default to steroids in my acute patients as a bridge to either a steroid wean or to IL-1 inhibitor therapy. The trial led to the approval was a little interesting. This is the Rhapsody clinical trial. They took patients with recurrent pericarditis who needed some sort of treatment and were on treatment, randomized them all to an IL-1, got them stable on the IL-1, then stopped the medication in half of them. And those that stopped it, surprise, they all flared. So even though this drug is billed as having a very, very high rate of success, it's being compared against placebo. But nevertheless, it's still an amazing steroid-sparing option, because you could argue patients probably should not be on chronic high-dose steroids for a long period of time. Now, the extension part of the clinical trial was interesting. They took patients after the clinical trial was done, and there were some patients that wanted to come off, 8 of them, for observation. And you can see here the freedom for survival in those patients that came off treatment. The majority of them flared, and they flared at a median of about 11 weeks, between 4 weeks and above. So this drug did not cure your pericarditis. It just treated the underlying mechanism, but didn't cure it. So I always talk about that with my patients. Just like we're not curing lupus by treating your psoriasis or rheumatoid arthritis or IBD, we're not curing your pericarditis. We are treating the disease pathophysiology. So we're not quite sure how long you're supposed to be on this medication for. And the other reason I really like to emphasize this is look at the median time to flare, 12 weeks. If you get an infection, you need to stop this for 2 or 3 weeks. If you're on a stable dose, you're generally going to be okay stopping it. There's a high likelihood you won't flare. So when I give an IL-1 inhibitor therapy, I start during the flare when corticoid or steroid dependent, or when I think they're going to have these recurrent episodes. I say, I don't want to talk to you about this for 6 months. You're going to be on this. Usually my threshold at this point is 1 to 2 years of treatment, and then we talk about the next steps. I get them off the NSAIDs, off the prednisone, and then we talk about colchicine. And I would say 90% of my patients I'm able to wean colchicine. I track blood work. I educate about the injection site reactions. We're going to talk about infections. And again, we'll talk about weaning in a second. So when they're ready to wean, and again, a normal MRI doesn't necessarily predict that we're going to have a successful wean. I do a slow wean and taper over time. I go to every 2 weeks for maybe a few months, every 3 weeks for a few months, every 4 weeks for a few months, until eventually we're ready to stop and I try to find the minimum dose that they can tolerate. I also pick a time in their life when they're comfortable, meaning I don't do this around major life events, major holidays, Christmas, Hanukkah, weddings, etc. We do this when they can have time, or if they're going to flare, they're going to be in a comfortable place where they can restart therapy if they need to. And similarly goes to anakinra. I've dose frequency changed, and as well as the amount you can draw of different amounts of anakinra, and that seems to help also. So when I start an IL-1 inhibitor, we talk about that this masks infection. This is the fever reducer. So we have a much lower threshold to send you to urgent care, to have a UA, to have an X-ray, to get a flu swab if you do have a fever. Just like you want to know if you had a fever before you take NSAIDs to treat the fever, you want to know if you had the fever, and then after that, you don't want to have the fever anymore. So it's a very similar concept. They don't cause opportunistic infections. And the one time I get really worried is in my transplant patients, where we've already blocked the adaptive response, and then I'm giving this IL-1 on top of that. I started to get pretty concerned, and I have a pretty high threshold to give them the therapy. We have 4 or 5 patients on it who have done quite well. But again, even though we don't typically think of being that immunosuppressive, when we're targeting both adaptive and innate immunity, I get a little concerned. If we do have an infection, if they do have an infection, they pause it for a week or 2 and the infection's cleared until they're finished with their antibiotics. And then generally we'll restart depending on where they are in the disease treatment. And if it's a complex infection, I'll sometimes ask infectious disease to weigh on as well. So again, to summarize some of the unknowns with IL-1s, we really don't know how long you're supposed to be on it for. And I do think, again, the way it's positioned is actually appropriate. It's steroid sparing. So probably the only wrong thing, and again, I didn't have the opportunity to go into the debate, is you probably shouldn't be on high-dose steroids for years. And so again, if the patient, you can't get them off steroids, I think that's kind of a no-brainer. And then whether you want to start it instead of steroids or you want to try steroids first, I'll leave that for people who debated this morning. I get hepatitis B, Hep C, HIV. I get quantiferin gold. I make sure they're vaccinated. You can vaccinate patients on this medication as long as it's not alive. We don't like you to have an active malignancy. That's a whole other separate topic. And then I recommend still the strep pneumo, the flu, the zoster vaccines. If you've been exposed to hepatitis B, I still send you to ID to monitor for recurrence, specifically with hepatitis B antigen and with RNA as well. I do roughly monitor to the best of my ability CBC LFTs, and again, we talk about that weaning plan. So thank you for having me. So in summary, most patients with acute pericarditis will do quite well. We do have to watch out for recurrence. I get a biased view because I've seen the recurrent pericarditis patients. I try to use steroids as minimally as humanly possible, and as soon as I reach first steroid, I'm already thinking about should I be on an IL-1. MRIs can be helpful, and rilonacept, at least in the States, is FDA approved, and at least from the old guidelines, steroids and anakinra are perfectly acceptable. Immune and methotrexate, really I only use adjunct therapy when they're on an IL-1, and then that's only with rheumatology involvement. So thank you very much, and it was a pleasure getting the opportunity to speak with you.
That was wonderful. Thanks so much, Mike. That was what a great talk and great overview of a complex topic and something that's rapidly evolving. And it was you gave a perfect synopsis of it. So thank you. We'll hold questions just until the end of after all speakers have gone. So I'll take this opportunity to introduce our next speaker. Welcome to Dr. Kafil, who's a cardiologist with expertise in cardiac imaging and heart failure, and also an assistant professor of medicine at the Mayo Clinic in Rochester. Tahir did his internal medicine residency and cardiology fellowship at Western University in London, Ontario. He then came here to Ottawa to do advanced heart failure training, and then went down to do imaging training in Cleveland, Ohio. With Alan Klein et al. And then after completing his clinical training, he started on it as faculty at Mayo Clinic, where he's active in the Centers for Cardiac Sarcoidosis as well as pericardial diseases. He's a great friend and colleague, so it's my pleasure to have him join us today to talk about imaging in pericardial disease. So Tahir, take it away. Thanks so much.
Thanks so much, Kevin, for that kind introduction. Now let me share my screen. Let me know if you guys can see my screen.
Yes, we can. Yeah.
Perfect. Well, first of all, thanks so much for the kind invitation. It's so nice to be here with you all. I'll take the next few minutes to talk about myocarditis and pericarditis overlap syndromes. It's a topic that's very near and dear to my heart, something I've been thinking about for the past 15 years or so. I have no disclosures. So the learning objectives, we're going to talk about the individual diagnostic criteria and then how do you diagnose overlap syndromes. We're going to talk about the interpretation of cardiac MRI and how to differentiate these conditions. And then what do you do for management and what evidence is there for the management of overlap syndromes? So we'll start with a case. So this was a patient I saw when I was a heart failure fellow in Ottawa. So this is a 31-year-old previously healthy woman who presented 5 days after her boyfriend tested positive for COVID infection. She presented with fever, hypotension, muffled heart sounds, distended jugular veins. Echo showed a moderate pericardial effusion and cardiac function was about 30%. She stabilized after an urgent pericardiocentesis, but then 12 hours later required an impella. This is an apical 4-chamber view of her echocardiogram, and I just want to draw your attention to her left ventricle. So, severe LV dysfunction. And interestingly, the LV size is not dilated, and so the size is relatively preserved, suggesting this is a very acute phenomena. So this was the impella, and so this is a TEE, and you can see the impella coming down through the aortic valve there and resting in the left ventricle, and you still see a little bit of pericardial effusion. Now, we did do the biopsy at the same time as when they were putting in the impella, and the biopsy actually came back completely negative. This is a cardiac MRI of the patient, and this is a short axis view just to orient everyone. This is the left ventricle, in the middle is blood. This is the right ventricle, in the middle is blood. This white stripe, signal enhancement surrounding the heart is the pericardium, and this is quite bright, suggesting there's, quite active inflammation there. There is a little bit of myocardial LGE there as well in the red arrow, but certainly the pericardial enhancement is the more prominent. So a question for you to think about, what would you do next in this situation? Would you use corticosteroids, NSAIDs, colchicine, or both 1 and 3? And we'll come back to this. So pathophysiology and the individual diagnoses. An important concept that's we tend to think of these diseases as single snapshots in time, but it's important to recognize that they do evolve. So inflammation evolves, and so a lot of the patients will come in the acute setting, so the acute injury. So this was a nice paper from 2021 illustrating a viral MyoPERIcarditis, and so in the acute setting there's edema. Then it evolves into the subacute. Some patients, the LG gets, very minimal. You barely see it. Others, the LG persists. A lot of times the edema will go away very soon. And then some people will have a grumbling, ongoing, low-grade inflammation. And so depending on what stage the patient is in their disease, they'll present differently and the findings will be different. So the clinical presentation, so pericarditis, right? So you have the chest pain, pericardial effusion, tamponade. Myocarditis, you'll have chest pain, arrhythmias, heart failure, cardiogenic shock, sudden death. But if you have an overlap syndrome, like the patient I just presented, you can have all of the above. So quick recap. So when you're diagnosing myocarditis, there's 3 steps. First is, exclude the alternate causes of presentation, so coronary artery disease, for example. Apply the myocarditis diagnostic criteria. And then last, you do need to evaluate for the etiology of myocarditis. And I think this is the part most people will sort of skim over. So similar to what I was explaining earlier about the evolution, so this is now reflected in the updated ACC guideline for myocarditis, and so there are stages of myocarditis. Stage A is if you're exposed to the risk factor, such as a checkpoint inhibitor, but you don't actually have myocarditis yet, and so that would be a stage A, so at risk. Stage B is you have some objective abnormalities, but no symptoms. And so we'll often see this in our checkpoint inhibitor myocarditis patients who have a troponin rise that's minimal, but everything else is normal. And so there's debate, what do you do? How closely do you monitor them? Some people will even admit these patients to hospital to monitor them. And there's a nice study that showed that some of these patients will even have biopsy-proven inflammation, despite having any, normal cardiac function and no symptoms. Stage C is where we think of the classic myocarditis. So you have symptoms and you have objective abnormalities. And then stage D is you have myocarditis and hemodynamic or electrical instability. So requiring inopressors or some, pacemaker, some intervention. Now, the pericarditis criteria, you're all familiar with. This has been also updated very recently. And so, the pleuritic chest pain must be present, although the difference with the ESC is it's not always needed, plus one or more. And so these would include pericardial friction rub on exam, the classic ECG changes, elevation in inflammatory biomarkers, and cardiac evidence of pericardial effusion, either new or worsening, and also cardiac imaging evidence of pericardial inflammation. So, cardiac MRI is obviously preferred, but CT can be an alternative. So the ESC uses the inflammatory myopericardial syndromes terminology, or the IMPS, and so both myocarditis and pericarditis they define as definite, possible, or unlikely. And so the way to think of it is the more objective abnormalities you have, it's definite, and then if you have some symptoms but no objective abnormalities, it's unlikely. So it's a spectrum there. So now that we've gone over the individual diagnostic criteria, let's come to the overlap syndromes. One challenge we have in researching this is that there is no ICD-10 code specific to these conditions. And so how widespread is the problem? We don't know. There's certainly estimates out there, but the precise, the prevalence is less known. Now, in terms of the ESC, so as I mentioned to you, IMPS is the new terminology, inflammatory myopericardial syndrome. And so, but important to recognize that this is just the initial diagnostic umbrella term until a final diagnosis is made. Myopericarditis is predominantly pericarditis. Perimyocarditis is predominantly myocarditis. The one caveat to that is there is some controversy, right? So the Europeans and the European guidelines very clearly differentiate, but the ACC doesn't, okay? So you'll find in a lot of ACC documents, the single term myopericarditis is being used for both. And this is in the 2024 updated ACC guideline of myocarditis as well, that if pericarditis complicates any stage of myocarditis, it's myopericarditis. And so again, just big picture, myopericarditis, predominant pericarditis. So you'll have normal ejection fraction, but troponin rise. And then perimyocarditis is now you actually have the cardiac function is reduced, or you have a wall motion abnormality. The spectrum is the challenge, and so I think this is why some people prefer to use a single term, because people can be all over the spectrum of this condition. You can start as perimyo, then become myoperi. And then some people will be in the middle, such as the patient that I presented. They have features of both. But the point being that just as I started with to explain that inflammation evolves, same with these conditions. Where things will rest, you have to follow your patient closely to see. Now coming to the MRI. Now, we'll do a quick overview of the terminology. I know there's a lot of non-imaging folks here as well. So the edema, right? So T2 mapping or T2 weighted imaging is to help us see edema in the myocardium. And then tissue injury, so late gadolinium enhancement. So that tells us, scar. If it's an acute situation, it might not be scar. It might be acute necrosis, extracellular edema. Elevated T1 times is sort of a grab bag of several things. And so, you have edema, intra or extracellular, hyperemia, necrosis, fibrosis.
Yeah.
And then ECV is calculated with the pre and post T1 times in hematocrit, and so this captures extracellular edema, hyperemia, necrosis, fibrosis. ECV tends to be more robust than T1 times alone. So in terms of the myocardial LG patterns, so there's ischemic versus non-ischemic. And so here you can see the subendocardial, that looks very ischemic or like transmural infarct. And then the non-ischemic patterns, which we'll often see in myocarditis. And so as you see here, myocarditis is listed in several of these different patterns. And so things like sarcoidosis and myocarditis can sort of mimic. The most common we'll see in our viral myocarditis patients is this lateral wall subendocardial LGE. This is an example of a patient with myocarditis. This is a young woman presented with fever, high troponins, and coronary angiogram was pristine. This is the short axis view showing wall motion abnormality specifically in this area. And if when we're giving the gadolinium, it's called late gadolinium, so we have to wait. And so during that time, we're obtaining our cine images, and you can see already the gadolinium seems to be accumulating there. Now this is an LGE focused view, and so here on the PSIR you can actually see the enhancement. And so dark here, this is healthy black muscle, and then the scar is this bright enhanced signal there. And so sometimes, as I explained to you, myocarditis and sarcoidosis can mimic sometimes even ischemic patterns, and so you just need to be mindful of the mimickers. And then this is the edema sequence. And again, on the same area, you can see the signal is a bit enhanced. And then this is T2 mapping. This is, very nice, so the upper limit of normal is 50 milliseconds on this magnet. And so you can see most areas is less than 50, but in that specific area, it's close to 60. So that this is a pixel by pixel assessment of edema. This is T1, and if you look to the left, you can see the legend. And so the closer to white it is, the higher the T1 values, and you can see the color is brightest here. And so you're sort of building a case that certainly, from a tissue characterization perspective, this is fantastic. So coming back to the revised Lake Louise criteria, so you need, something from edema, right? So either the T2 stir or the T2 mapping, like we want. You need one marker of injury, so either a T1, an ECV, or an LGE. And then you also have some supportive criteria. So pericarditis is actually a supportive criteria of the Lake Louise. And so that already tells you, when people are thinking about these conditions, there's so much overlap. And then systolic dysfunction. Just a small caveat. So although I said you need one of each, the authors of the Lake Louise criteria really did go out of their way to emphasize that that's not the case. In the correct clinical scenario, even one can be sufficient to support the diagnosis of myocarditis and acute inflammation. So that's a clarification point. So if you have even one, so either a T1 or a T2, and the correct clinical scenario can be supportive. Now, a lot of the times these patients do show up undifferentiated, and so sometimes there is value in repeating the MRI. And certainly in my practice, I do repeat the MRI, especially if the patient's initial MRI is quite abnormal. And so, this is just a nice example of showing how the LG pattern evolves. And you can see the edema up here actually significantly improved. And then the LG also became a little bit smaller. And so this patient responded very nicely. And so this is just an interesting historical point. So in the original Lake Louise criteria, there actually was a sentence in there: a repeat MRI between 1 to 2 weeks can be considered after the initial MRI. Now, for practical purposes, it's so difficult to even get one MRI. Repeating the MRI in 2 weeks in practice is very difficult. But the concept is there. So even then, they knew this concept of inflammation evolves, and when you do the MRI can influence what you see. So coming to the pericarditis, and so there's 2024 position statement where we're trying to get people to standardize how we're reporting pericardial LG, and we have a forthcoming paper on this as well. Essentially, it's none or mild, moderate, and severe. And so there's three parameters we care about. We care about, is it 50% of the circumference or less? We care about, is it more than 3 millimeters or less? And we care about, is it in all three slices, so the base, mid, and apex, or less? And so depending on what permutation you have, you can sort of classify this. Now, again, one of the challenges with this is there's a lot of inter-reader variability. So reasons for false negative CMR. And so, often, and this is important because I do emphasize that myocarditis is not only an MRI diagnosis. And so, especially in centers and settings, low resource settings, where we don't have access to MRI at all. And so, suboptimal imaging quality. And so if there's artifact, for example, you can miss the LGE, very early disease, or you may have some edema, but not as much LGE, very diffuse disease. And so I have seen some very fulminant cases of myocarditis or sarcoidosis where everything is just so enhanced, it's difficult to know where's the normal part. Inter-reader variability and fixation error. Fixation error I just mentioned because sometimes if you order an MRI for pericarditis, they'll focus on the pericardium and sometimes not look at the myocardium as closely, and vice versa. So just important that when you're assessing for myocarditis, you're also assessing for pericarditis. Now, what is the evidence for treatment in these overlap syndromes? So there's limited evidence, but there is evidence. So I'll present three studies. The first is a study from Italy where they looked at three groups of patients: pericarditis, myopericarditis, and then perimyocarditis. Perimyocarditis was a handful, only 26 patients. They defined as troponin elevation plus focal or diffuse depressed LV function. What is important to note is that both groups, the LV function wasn't terrible. Okay, the worst patients, it was only about 44%, because that influences how you interpret the results. If you look at the follow-up for recurrence, both myocarditis and perimyocarditis was actually very good, but with the caveat there was only a handful of perimyocarditis, and most patients had preserved LVEF. So they said, most of these patients normalized their cardiac function, and the recurrence rate is very similar. There were no deaths. And so what you can take from that study is troponin elevation is not associated with increased complications in myopericarditis, provided the LV function is relatively preserved. The second study is from Switzerland. So they looked at about 45 patients using the sort of the ACC terminology of myopericarditis, of any inflammation in the myocardium and pericardium both. And again, preserved ejection fraction. They treated patients with NSAIDs versus no NSAIDs. And so what was very interesting about this study is patients who were treated with NSAIDs had a greater reduction in LGE burden. And the follow-up, there were no deaths, no heart failure. One patient had non-sustained VT, but certainly the bottom line was NSAIDs, if the cardiac function is preserved, can be relatively safe in myopericarditis. Now, this is reflected in the guidelines for symptom management, but again, sometimes you should just be cautious, especially if the LV function is borderline. The third study is also from Italy, and so they looked at 146 patients with myopericarditis, preserved ejection fraction, and so they treated these patients with colchicine. And they actually found patients treated with colchicine had fewer recurrences, and so that this was actually pretty strong, suggestion that treating these patients with colchicine has fewer recurrences. And the ESC 2025 guideline, it is a 2A for myocarditis as well. So bottom line, colchicine is safe and prevents recurrence in myocarditis, again with the limitation that these are all majority preserved ejection fraction. So how do you actually manage these patients in the real world? So if you look at the older 2015 guideline, there really was not much. The main thing they said was, rule out coronary disease, and then cardiac MRI is recommended, a few other things. The 2025 also doesn't give that much guidance on what to do when there's overlap, and so they have this one sentence: for combined conditions, the leading one, the myopericarditis or perimyocarditis, should guide the therapeutic decision-making and subsequent follow-up. So what I want to share with you is, so we've done a Delphi study on this topic that's forthcoming, and we have an algorithm, sort of a tailored approach. The message is, more than we're appreciating. I think we're sort of underappreciating how much overlap there is in these syndromes. You do need to address each component, individually. And so in my patient, for example, we did need to do the pericardiocentesis because they did have tamponade, the exercise restriction for pericarditis, etc. And then also the myocarditis component. So all of the things that you would need in myocarditis, you would do. And then you have to reassess the patient. So similar to how the ESC comments on the IMPS phenomenon being an initial umbrella term until a final diagnosis is established. So you do in short-term close follow-up, repeat the echo, repeat the MRI, see where the dust settles, and then depending on what's predominant, you can sort of treat them according to that predominant condition. Now, in terms of clinical pros, just remember to reassess. And so even in the emergency department setting, the picture can evolve so quickly, and then even a couple of weeks out, a couple of months out. And so I do follow my patients pretty closely. Team approach is certainly helpful. So, you work with all of your colleagues, the imagers, the heart failure docs, the rheumatologists, whoever's needed. So just coming back to our case in the last few minutes, so the 31-year-old who developed COVID myocarditis, so we did treat her with both steroids and colchicine, and so she was very, very sick. We pulsed her with steroids, and it was remarkable. Within a week, her cardiac function went back to completely normal. She was walking around in the hallway asking to go home, and we actually had to debate: do we even need to do the MRI if she's back to normal and she wants to go home? Luckily, she got the MRI, but it was just a remarkable case. And then we did put her on colchicine as well. So take-home points. So the overlap syndromes with preserved ejection fraction have a good overall prognosis. The cardiac MRI is the strongest non-invasive tool for this condition, but you do need to interpret it in the clinical context. You should know when it can be a false negative or positive, and then the timeline. And then the management, you just make sure that you're addressing each component separately and following them closely to see where the dust settles. And then the team approach is critical. With that, I thank you for your time.
Thanks so much to hear. That was wonderful. Again, great overview of a field that's very quickly evolving and actively under research at the moment. So thank you so much for providing your oversight and expertise in this important area. All right, and again, we'll save questions right till the very end. I want to make sure that we have ample time for each presenter. So last but not least, I'd like to welcome Dr. Hassanabad. He is a cardiac surgeon scientist. So he completed his cardiac surgery and PhD training actually last June at the University of Calgary. So congratulations to him on that milestone. That's fantastic. And his doctoral studies focused on the pericardial space and more specifically established the immune profile of the pericardial space in patients undergoing various types of cardiac surgery. And furthermore, he demonstrated the contents of the pericardial space have biological and functional relevance, and his overall research goals revolve around the fundamental belief that the pericardial space has diagnostic, prognostic, and therapeutic potential. So I'm really excited to welcome him here today and hear him talk about this research realm today with us. So without further ado, I'll hand the reins over to him. Thanks so much for joining us.
Hi, thanks so much for the kind invitation. Can you guys hear me, first and foremost?
Yes, we can. Yep. Yep.
All right, and I'm going to reshare my screen because I don't know what happened last time. And then can someone confirm whether they can see my slides?
Yes, we can see your slides. Yep, that's perfect.
Perfect. All right, thanks so much. Well, thanks again to the organizers for having me. It is a great privilege to be able to present to you guys. I am very fortunate that I'm going after some clinical talks because I think this talk is going to be a bit different. And over the next 20-25 minutes, I want to make the case that maybe we should look at the pericardial space in a different way. So this is the title of my talk, The Pericardial Space, a Non-Inert Milieu with Clinical Implications. All right, so I have no disclosures. It's a good thing about being a fresh grad. So just to set this up for everyone, so let's just talk a little bit about things that us in cardiology and cardiac surgery deal with on an almost routine basis. You've got heart failure, coronary disease, valvular disease, atrial fibrillation, both incident and post-op. And then you've got post-surgical pericardial adhesions, any surgeon's nightmare. And all of them have a few things in common. Their precise mechanisms are not well explained. Inflammation is known to drive all of them. And then the role of the local environment has never been properly studied, in my opinion. So the other part I want to highlight here is that, again, just taking two examples, you have a patient with heart failure and a patient with heart attack presenting. What happens? The first thing that we do is we draw systemic blood and look at circulating markers. But what about the pericardium? What about the area that's right precisely outside the heart? Have we ever thought about, okay, what's going on in that area? And then what about pericardial fluid? Well, does that even matter? Up until now, this gold-looking fluid, admittedly, it's not always this clean, has been thought to be just a mechanical barrier, protecting the heart, preventing it from sudden insults. But maybe there's more to it. When you look at it broadly, you've got two components. You've got an acellular component, and then you've got a cellular component. I don't know if the audience can see the pellet down there, but that's how it looks like when you spin it. And I'm going to, again, over the next 20-25 minutes, talk a little bit about what's inside this fluid, and more specifically, what's inside these components, and do they even matter? If so, how do they matter? And this is where we put out a short review a while ago, I think it was last year, about the diagnostic, prognostic, and therapeutic purposes or potential of the pericardial space. And I want to highlight how we can get there and why we could get there. So for today's talk, I'm going to focus on three objectives: characterizing the immune profile of the pericardial fluid. And I'm going to show you that there are different mediators in there that matter a lot. I also want to establish for the audience that these components have biological functions. They are active. And then and last, I want to talk about what happens after surgery. And the unifying theme in all these three areas is that this is a very dynamic environment. And the dynamism is not just in response to injury, but it's also in response to different cues that are brought together by the heart. So it is a truly unique environment. So with that, let's talk a little bit about the pericardial fluid immune profile. So for this part of the study, what we did was we enrolled patients. These were all cardiac surgery patients in Calgary. We decided to take patients presenting with an ACS, and we took as a surrogate for control patients with valvular disease that didn't have any obstructive coronary disease. The one limitation, obviously, as you all know, is there is a degree of fibrosis with patients with valvular disease, but we tried to control for that by looking at EF. We didn't have any CMR to be very precise, but beggars can't be choosers when it comes to collecting patient samples during COVID. And what we did was we took their pericardial fluid. And the first thing that we did was we decided, all right, let's take a holistic look and look at the cellular component. So we did flow cytometry, and this might not be earth-shattering, but we were able to say, all right, there are a gamut of immune cells that are present in native pericardial fluid. And this was done before the institution of bypass. No steroids were given. The only anti-immune or immune-mediated medication was the ANSAF that was given before cutting skin, and no heparin was given either. So as baseline and native, as you can imagine, notwithstanding their presenting disease and their comorbidities. What we also found, which was very intriguing for us, was that the duration from their event, from their ACS event, seemed to affect the composition of some of these immune cells. And I want to draw your attention to the T cells and the macrophages. And the reason for that is because these are the two most prominent in terms of cell number, cell type in the pericardial space, but also because of the reparative roles that especially the macrophages have. And you can see that as you move farther away from an ACS event, you get a repopulation of these cells. Now, does that mean that the heart is trying to reestablish an equilibrium, a new homeostatic environment? We don't know yet. But the point is, it is dynamic and it responds to a heart attack. What we then did was we looked at the acellular component, and here's a heat map. The brighter the color, the higher the concentration. And again, these Greek letters just denote the significance between time points. What I want to draw your attention to is twofold. First of all, not everything is elevated. There are some markers that are elevated and some that aren't. EGF isn't, TGF is. But also looking at the difference between groups, time from event matters. We look at also chemokines, same sort of trend, cytokines, same sort of trend. And then also looking at the MMPs and TIMPs, as many of you know, the MMPs and the TIMPs are very important in cardiac remodeling, especially with collagen deposition. And as you can see, there's no significant differences in MMPs within these time points. But when you look at TIMPs, especially TIMP1, which is the most well-established one for remodeling, you see again differences, and it's highest right after the heart attack, and you can see a progressive decrease in their concentration. So the next question we asked was that, okay, all these meters are good, but where are they coming from? Is it all coming from, as was previously thought to be, from just an effusate from the lymphatic system, from blood? Where is it coming from? And for that, we decided to, again, take a very eagle's eye approach and collect pericardium, appendage, and then we also took the same cells from the same patients. And we decided to culture these 3 different tissue sources. And as you can see, so here PFC means pericardial fluid cells. Compared to media in white, there's differences. So suggesting that pericardial fluid cells can secrete TIMP1, TIMP2, FGF2, IL-10, and so on and so forth. We also looked at the pericardium and appendage, and once again, you see that some of these sources are more powerful, if you will, in producing some of these mediators. The part that was really interesting for us was that we were able to show that with what's in the pericardial space compared to what's circulating, there's differences. And you can here, I'm going to just draw your attention to a few of them. So interferon alpha-2, IL-15, and then IL-6. So the previous 2 talks beautifully summarized all the medications that we give to these patients that come in with pericarditis, myopericarditis. But what's circulating is very different than what's actually in the space around the heart. So maybe we should take a different look at the space around the heart, and maybe we should think or start thinking about how do we address this more locally. Again, the first talk in this session was about the side effects of a lot of those medications, and they're not benign. We also look at chemokines and growth factors, and again, you can see differences with what's circulating and what's in the pericardial space. Same idea with MMPs and TIMPs. Again, with the TIMPs, some very significant differences. So to summarize, the first part is that immune mediators do indeed populate the pericardial space. Different tissues around the heart do contribute to that profile. Disease states, so whether you have an ACS versus valve disease, does inform some of those differences. And timing matters, and it makes a difference. It does make a difference. And importantly, and this goes back to the design of agents, therapeutic agents, the changes are not sweeping. They're not universal. Not everything gets nuked in a way that everything increases. And so you can be very precise in how you target some of these markers. And then most importantly, in my opinion, is that the pericardium profile is distinct. It's very different than what's circulating in blood. I'm going to pivot a little bit here and talk about each of those components. And I'm going to focus on the fibrotic properties of each of those. So again, focusing on the cellular and acellular components. The first thing we did was we took the acellular component. We started calling it the supernatant or PF pericardial fluid soup. And what we did was we cultured it with cardiac fibroblasts. So these were right atrial appendage derived cardiac fibroblasts. and we put some of this acellular component of pericardial fluid, and we did a rat tail collagen assay where the higher contraction was indicative of more fibrotic activity. And to our amazement, we saw that when you add the pericardial fluid to the fibroblasts, they become more fibrotic. Interestingly, there's again differences between patient groups, CABG versus valve. You see within the CABG patients at 48 hours, there's already a statistically significant difference in terms of fibrotic activity, whereas in the valve group, you don't see that. So we decided to ask what may be driving this. We took those cardiac fibroblasts and we did bulk RNA sequencing. And lo and behold, TGF-beta, or the transformation growth factor beta pathway, was implicated. We blocked TGF-beta in the same conditions, and we were able to show, reverse that profibrotic activity of the pericardial fluid supernatant. We then said, all right, so the acellular component, or the supernatant, is profibrotic. What happens if we take the cellular component? So we did the same thing, and conversely, the cellular component is protective, so it reduces your amount of contraction, again, showing, indicating that it prevents or blunts or attenuates fibrotic activity. This part, and this is currently at under review JCI Insight, we did single-cell RNA sequencing using the pericardial fluid cells of patients who had a recent ACS event versus those who've had valvular disease. And we found at a more detailed level different populations of cells. Specifically, there's different populations of macrophages. And the reason why, again, we focus on these macrophages is that we had previously shown that macrophages can translocate to the myocardium and help not only prevent fibrosis, but even reverse a little bit of it. And this was using murine models. And so this was very interesting for us to see it in the human context as well. What we then did was we took these macrophages and we put them either in direct contact with the cardiac fibroblasts or separated. And we saw that in both cases, they were able to attenuate fibrotic activity, suggesting that whatever they're producing or secreting may have a paracrine effect. So we did some proteomics. Here we took mass spec, a mass spec approach, and what we identified was cystatin C. I don't know if much of the audience is aware, but cystatin C is making quite some waves these days. It's been classically known as a marker of kidney disease, along with creatinine, but it's more and more becoming implicated in cancer. And now I think there is some crosstalk with heart disease as well. And what we found was that these macrophages are able to, so here in the first panel, down the bottom macrophages, and then you see cystatin C, or CST3, with the biggest circle, are able to produce it. What we then did was we went to our pericardial fluid cells, and we, just to show that it is indeed the macrophages that are producing it, we took the T cells, so these are the CD3 positive cells in orange, and then the CD14 positive cells, these are the macrophages. And you can see it's the macrophages that are producing the cystatin C. Moreover, you see that there's a difference, again, between patients without any coronary disease versus those who had an MI. We further blocked cystatin C, and we were able to show that we reduce that antifibrotic activity, again, giving us more reassurance that cystatin C is an important player here. We then did the painstaking exercise of developing novel mouse models where we knocked out cystatin C, and I'm just showing here some of the data in mice, and we were able to show that. I'm going to just draw your attention to the far right here, panels D and E, where in the knockouts, which is in red, you see more scar size and more fibrosis at the border zone and the scar itself. So to summarize this part of what I'm trying to convey to you guys, the acellular component of human pericardial fluid can drive fibrotic activity, and more specifically, it can do it through the TGF-beta signaling pathway. Conversely, the cellular component can blunt it, and it can do that through cystatin C. NMI does shift the pro and antifibrotic capacity of pericardial fluid components. Again, I didn't show all the data, but we've also done work with extracellular vesicles which also feeds into this as well, where we've been able to show that different sizes of these EVs can have pro-angiogenic benefits. The last part of my talk, and this is going to be the part that is the most surgical part, is talking about how this environment changes after surgery. Up until now, everyone within cardiac surgery has believed that once you do heart surgery, the blood that accumulates in the pericardial space is the same blood that's in your arteries and your veins, and there's not much differences. I'm going to show some data that suggests maybe that's not really entirely true. So for this part of the study, we took patients that were undergoing heart surgery. We took both full sternotomy patients, so these are conventional median sternotomy. We also decided to take patients undergoing minimally invasive cardiac surgery. And what we did was we took their native pericardial fluid, but we also left a drain in the pericardial space. And one of these studies that has looked at pericardiectomy, I think was highlighted in the first talk of this session by Gaudino and Lancet, which gives, again, a lot of credence to what we're seeing here. And what we did was we collected that effluent or that post-cardiotomy fluid at different time points. We decided to focus at 4, 24, and 48. For some of these patients, we went as far out to 72 and 96 as well. But especially with the minimally invasive patients, from an ethical perspective, we had to pull the drains because they were ready for discharge. So we decided to just focus on the first 48 hours. And as a first take home, you see that the space is repopulated with immune cells. And again, there's a whole gamut of immune cells that populate the space after surgery. And same idea with the inflammatory markers, whether it's MMPs, TIMs, growth factors, chemokines, cytokines, you see differences. And importantly, differences, again, these Greek letters denote the significance between time points, is that there are very distinct differences at different times after surgery. So whatever is governing it, that space, it's very unique to that space. The cues that are given are very unique to that space. But since we had enrolled patients that were going for minimally invasive surgery, we also compared to see if the size and site of location make a difference. And to our curiosity, it wasn't as robust as we thought it would be. And the more that we think about it, the more it makes sense. It's not a matter of where you make the incision on the skin. It's where the manipulation happens around the heart. But nevertheless, there were still some differences between the two groups, and specifically with neutrophils and macrophages and different time points as well. When we submitted that paper, some of the reviewers asked us, so what about, how can you show us that the differences that you're seeing is not just the blood that's circulating, and how can it not be just the differences from post-cardiopulmonary bypass, the pump? So we decided to compare what we saw in the pericardial space with what we see circulating in blood. And lo and behold, there are differences. It's not the same. So here, just to walk you through these figures, on the left, we have baseline, comparing between pericardial fluid and blood. On the right, we have postoperative, so at 48 hours, and we just decided to focus on 48 hours. And you see that differences in baseline, for example, neutrophils, they're gone at 48 hours. Differences in CD163 macrophages at baseline, they're still there, but much less pronounced. And again, the differences are not sweeping. They're very precise. They're very unique to specific cell populations, specific mediators, suggesting that whatever is governing that environment, it's very specific and precise. We also looked at pro and anti-inflammatory cytokines, and again, we see there are different trends between blood and pericardial space before and after surgery. And same idea with MMPs. So we see what populates the pericardial space before and after surgery is very different in terms of the population of MMPs, and especially with respect to TGF-beta as well, going back to the role that TGF-beta has in fibrosis and cardiac remodeling. So to summarize this part, cardiac surgery does elicit an inflammatory response in the pericardial space. The degree of surgical manipulation, so conventional versus minimally invasive, does appear to influence the kinetics of that inflammatory response. And then, in my opinion, the most important finding from these two studies has been that the response that happens in the pericardial space is distinct when compared to what's circulating systemically. So going back to what I first presented to you guys, different disease processes, none of which is fully understood, can maybe be highlighted by what's happening locally, that the pericardial space is enriched with immune mediators. It is a dynamic milieu. It's not inert. It is responsive to stimuli and injury. And that these stimuli, these insults, elicit a response that's very precise and specific to that environment. And for these reasons, I think this is a perfect opportunity for us to take a moment and think about, all right, if these are realities, how can we then take this, the pericardial fluid or pericardial space or pericardial contents and think about them as potentially diagnostic, potentially prognostic, and then ideally down the road, is there a way for us to leverage the space in totality for therapeutics, introducing targeted therapeutics that can have very precise mechanisms and thereby reducing their systemic side effects. With that, I'd like to thank the funding agencies, the research team at Calgary, especially my supervisor at the time, Dr. Fedak, who's become more than just a supervisor. I'd like to give him a shout out here. And with that, I'd like to take any questions.
That was wonderful. Thanks, Ali. Thank you so much. I'll invite all 3 speakers to come to the virtual stage, and you guys can turn on your mics and camera. And at this point, I'd like to thank all of the speakers for the wonderful presentations today. It was really really great, and a very nice breadth of topics covered. So thank you all. For the audience, feel free to either drop in questions on the chat, or you can just unmute yourself and speak. I have a few questions for folks as well. Ali, oh yeah, sorry, I see Mike has his hand raised.
Sorry, I couldn't resist.
Yeah.
Ali, that was, I guess my question was directed to Ali too. That was amazing. I really enjoy it. I find there's so little work done in the translational component to pericardial disease. I have a question about pericarditis and what you find in the pericardial fluid. I feel like in acute pericarditis, we see a lot of neutrophils infiltrating, but neutrophils don't really have a lot of inflammasome, and so do you think those neutrophils are pathogenic? Are they just IL-8 mediated from some of the monocyte macrophages, mesothelial cells? I'd love to get your insight on that. And it goes to treatment too, because colchicine, I think, gets neutrophils and inflammasome, whereas IL-1 doesn't really inhibit neutrophils.
Yeah, thanks so much for the question. I greatly appreciate your talk and learned a lot. That was a good review of what I studied for the board exams that I very quickly committed to memory. It's a great question. So to answer your question, we don't know yet. So what we try to do with these studies, we try to actually collect fluid from patients undergoing pericardiectomy, coming in with fulminant pericarditis. The problem is they don't have much fluid. We also tried to collect their pericardium, and we did some basic rudimentary histology, and we didn't find much out there. So what we decided to then do was to go to a large animal model and create pericarditis. So we took pigs and created essentially pericarditis model. The problem we've had there that it's not consistent in terms of the pericarditis amount that we get. So we're not confident that whatever we're seeing is truly indicative of what's happening in a human setting. So I don't know. The answer to your question is I don't know. I do think that each of those cells, whether they're neutrophils, even the T cells, like the T cells, it's the one of the largest population of cells that are there. We don't know what their functional role is just yet. So what I've just presented here, I think is just not even, it doesn't even scratch the tip of the iceberg. I think there's so much more. But it does go to maybe putting the spotlight into the space and what's in the space for designing those medications or those targeted therapeutics, for sure.
Yeah, that's great. Thank you. I 100% agree.
Tahir, thanks again for your talk. I'm curious to see in both I guess, Cleveland and now in Mayo. How do you incorporate CMR into your kind of routine care for patients with pericardial disease? I.e., you have your patient coming to you with pericarditis. Do you routinely get a CMR in those patients? Are you only ordering it for kind of higher risk patients? Do you do it once? Do you do it multiple times? How are you guys using it?
That's a great question, Kevin. And certainly, I think I'm very fortunate to be in a very resource-rich setting where we can get the MRI the same Wednesday afternoon, right? And so that's not really realistic for most parts of the world, where the MRI wait list is 3 to 6 months, sometimes 9 months, and many patients don't even have access to MRI. They, for example, some parts of Africa, they're traveling, almost to a different country before they can get access. And so because we're more of a quaternary center, a lot of our patients will come already having had MRIs before. And so we always ensure that we get the images so we can review the images ourselves. We do imaging guided therapy, and Michael very nicely showed the imaging guided therapy paradigm that Dr. Klein and we use. And so certainly in IL-1 blockers or antagonists, we will do the baseline before starting. Now, whether you repeat it at 6 months, you're part of the Delphi that's forthcoming, and we'll sort of, be able to show some, what are the experts doing regarding this. I generally do repeat the cardiac MRI, especially if the first one is very hot and inflamed, just to ensure things are improving. I do repeat it before I'm stopping IL-1 antagonist, so that's another time point. I will repeat it. And then I do use it in patients with undifferentiated disease. And so, for example, I just saw a patient yesterday who's been diagnosed with chronic pericarditis for years, but she's had 3 completely normal cardiac MRIs. So again, knowing what we know about cardiac MRI now, if the cardiac MRI is pristine, there's no pericardial LGE thickening, there's no sequelae of chronic pericarditis, it's very unlikely that that's a pericarditis. Now, as you know, with the new diagnostic criteria, you sort of need 1+1, but I think, even in discussions I've had with Dr. Klein and several others, if the cardiac MRI is really, truly a high quality MRI, completely normal, like, my suspicion for pericarditis would be lower, even if they meet some of the other criteria. Hope that answers the question.
Yeah, that's great. That's great. And Michael, I don't know if your practice is similar, but I very much lean on CMR in these kind of undifferentiated cases. And I'm sure, folks that have patients coming to them with the query pericarditis or pericardial pain, it can be tricky to try to, tease apart what exactly is the etiology of their symptomology, but CMR is certainly proving to be very useful in that domain. And, for Michael, one of the things that I struggle with are in my folks that I have on interleukin-1 inhibitors, what is the ideal length of time to keep them on it? When should I think about tapering them off? That's something that I struggle with every single clinic. How do you approach that question? Once you have someone on a biologic, on, rilonacept or anakinra, how long do you keep them on it? And then how do you decide when they're ready to come off? I'm eager to hear your thoughts. Oh, Mike, you're on mute there.
Sorry. My own clinical experience is that a normal MRI does not predict recurrence. I've had patient after patient after patient where the MRI is clean and you stop and then they flare. So I think it's one part of the puzzle, as well. And I've stopped it even with a little bit of LGE and they've been fine. So I think I agree. If there's gross T2 or really diffuse LGE thickening, then I'm a little more cautious. So I do generally repeat the MRI to at least have some sort of improvement to make sure there's no constriction or no evolving constriction, et cetera. So after that, I go based on how long they've had the disease before I start as well, how incessant the course was, and usually I'll go to 1 to 2 years, and then I'll talk about weaning. And I really pick a point in their life when they're comfortable to have a flare. And we also talk about pregnancy a lot, because in my young women who get pericarditis, there's a kind of a time constraint as well. So sometimes they're willing, depending on when they want to get pregnant, and I don't necessarily feel comfortable with them trying to get pregnant on rilonacept, then we'll potentially do a slightly earlier, or we'll have to make more plans about when the appropriate wean is. So I'll generally go to every other week for a few months, every third week for a few months, and then try to find out what the minimum doses I can get them at. And then, and sometimes it's nothing, sometimes it's every third to fourth week. And that's been my own practice. I've tried adding colchicine on top of that. It hasn't really worked too well, but I sometimes will do that. And there's actually a clinical trial, Maverick. I don't know if you guys are a site for it, where they're testing an oral cannabinoid. So now I'm trying to get pretty much actually every patient into that because I'm still not sure what the appropriate therapy is. And it's a really important question to ask and answer. Oh, sorry, appropriate weaning strategy is.
That's great. Thanks, Michael. I know we're exactly at time here. There's one question from an audience member, kind of a difficult patient, or patient with difficult to control disease. As many of us in the pericardial realm have these patients, they tend to have kind of multi-morbidity, especially when they kind of get along the disease spectrum towards developing irreversible constriction. And I guess she commented that there was kind of organized pericardial calcification. I guess my experience, and Tahir, Ali, and Mike, I'd be interested to hear yours. But once there's constriction, and if inflammatory markers are if inflammatory markers are positive, that's actually a good thing, and that there's a treatment target there. I treat those folks very aggressively with anti-inflammatories, try to get their inflammation as low as possible. And then, once we've controlled their inflammatory disease process, I repeat the imaging to look to see if the constriction is reversible. But, there's, in my mind, there's kind of a window that you have to reverse constrictive physiology. And then once it's past that, it starts to become an irreversible process. And at that point, we consult our friendly neighborhood cardiac surgeons, Ali et al. And pericardiectomy is the way to go. And Ali, I defer to your expertise, but at least in my experience, the more extensive the pericardiectomy, the better in terms of relieving the disease process. And I agree with for these complex patients, investigating for other etiologies. And to hear, Mike, I don't know if you routinely look for TRAPS or other kind of genetic predisposition for pericardial disease.
So in terms of the second part to your question, I used to send everybody for whole exome sequencing with recurrent autoinflammatory disease, and I've caught zero. And also, it's pretty unique that we have that capability. We have a genetic rheumatologist, David Beck, who discovered Vexos syndrome, and so he loved to do this stuff. And once we started getting no hits, I kind of backed off a bit, with exceptions, right? If they have joint issues, all sorts of other things, weird rashes, I guess it kind of depends what the inflammatory phenotype is. But I've gotten less aggressive over time, unless there's other stuff besides just idiopathic pericarditis.
That's great. Yeah, I mean, I've had similar, similar luck fishing for kind of genetic etiologies. I had, one patient that was, with a strong family history, including a twin with with pericarditis, and recurrent pericarditis, and genetics were negative, but obviously we're just not picking up whatever the genetic etiology is in that family. All right, I recognize we're beyond time. I'd like to really send a special thank you to all of you on the panel. Hearing your talks, it was just fabulous. I learned so much from each and every one of you. So thank you so much. Thanks to the audience for tuning in. It was a real treat, and thanks to the organizers and the Heart Institute for hosting this great event and for having us. And again, putting a plug in for Dr. Garshick's symposium in April. You guys should all check it out. It promises to be an excellent event. So thank you all, and have a wonderful weekend.